Assalamu alaikum. We'll start the second. Part of the clinical round revision. Start with slide 40. What are the causes of asymmetrically enlarged uterus? Causes of asymmetrically enlarged uterus include coronal pregnancy or pregnancy in uterine hole, fibroid, which are multiple fibroid, uterine fibroids, or subserous type 6 or type 7 fibroid, adenomyosis of localized type, hematometria in a non-communicating hole. Other conditions that cause asymmetrical enlarged uterus include dense pelvic adhesions, including the uterus within it, such as tuberculosis, endometriosis, tuboovarian malignancy, and prior extensive specially bowel surgeries. The next slide mentions the differential diagnosis of cervical enlargement. The cervix may be enlarged with due to congenital hypertrophy of the cervix or elongation of the portion vaginalis, which was called previously as a false prolapse. Granulomatous lesions as syphilis, syphilitic gammas, tuberculosis of the cervix, bilharziasis, amebiasis, or actinomycosis are causes of cervical enlargement. Chronic cervicitis, including these types, chronic endocervicitis, this is called chronic non-specific cervicitis. However, granulomatous lesions are chronic specific cervicitis. Chronic non-specific cervicitis, including endocervicitis, interstitial cervicitis, cervical erosion, Nabuthine follicles, mucus cervical polyps, or cervical ectropion. These are all causes of enlarged cervix. Cervical ectopic pregnancy and cervical abortion, how to differentiate between them? Simply by evaluation of the internal cervical os by ultrasound, transvaginal ultrasound. If the internal cervical os is closed and the gestational product and or gestational sac below the internal cervical os, between the internal cervical os and the external cervical os, let's say in the cervical canal, this is an ectopic cervical pregnancy. While if the internal os is opened, it is a cervical abortion, which is a subtype of inevitable abortion in which the internal cervical os must be opened. Cervical polypi, whether true or false corporeal polyps passing via the cervix. How to differentiate? By trying to rotate a uterine sound around the pedicle of this polyp to 360 degrees. If the circle is completed, so the polyp originates from higher up than the cervix. It is uterine on origin. While if the sound cannot complete the circle, so the origin of the polyp is in the cervix, and so this polyp is truly cervical polyp. Cervical endometriosis, which is a rare condition, and cervical neoplasm, especially cervical fibroids, which may be central or anterior or posterior, or pseudo-cervical fibroid are originating from the broad ligaments and appears as cervical fibroid, or maybe malignant lesion as cancer cervix. What are the differential diagnoses of vaginal swellings? Vaginal swellings may be listed in this table, simple table. We divided these vaginal fibroids into, vaginal swellings into cystic swellings and solid vaginal swellings. The cystic swellings include Gartner cyst, which is a vestigial remnant, hymenal cyst, endometriotic cyst of the vagina, vaginalis infestimatosa, implantation cyst as dermoid, pseudo cysts such as prolapse, cystocele, rectocele, enterocele, erythrocele, and maybe hemangiomas and lymphangiomas. Solid vaginal cysts may include fibroma, vaginal fibroma, which is rare, neurofibroma, organized hematoma, vaginal cancer of old age, foreign body granuloma. These are the vaginal differential diagnosis of vaginal swellings. We come to what are the differential diagnosis of vulvar swellings, vulval or vulvar swellings. Vulval swelling may be swelling of non-vulval origin and appears as a vulva, such as anterior wall as erythrocele, cystocele, Gartner cyst, urethral diverticulum or urethral crancle, posterior vaginal wall as rectocele or enterocele. These are all false vaginal, so false vulval swellings. Vaginal vault as vault prolapse. The cervical lesion that may arise from the cervix and appears at the vulva as a false vulvar swelling, such as congenital elongation of the fossa vaginalis, second-degree uterine descent, according to the old staging or old classification of the uterine prolapse, cervical polyps that may have long pedicles and reach the vulva. Third-degree uterine descent, uterine inversion, chronic uterine inversion, pedunculated corporeal fibroids may constitute or may be a differential diagnosis of vulvar swelling appearing at the vulva but of non-vulval origin. However, some rare conditions such as hydrocele of the canal of neck and inguinal hernia appear as cysts, cystic swelling at the mons and the groin region, and may be considered as differential diagnosis of vulvar swelling because the vulva includes the mons veneris. However, vulvar swelling of vulval origin includes cysts as Bartholin's cyst, sebaceous cyst, endometriotic cyst, hymenal cyst, clitoral or carotid cyst, implantation, dermoids. Traumatic as vulvar hematomas. Inflammatory masses such as Bartholinitis, Bartholin abscess, condyloma acuminata, viral by human papillomavirus, or condyloma lata by Streptonema pallidum of syphilis, lymphogranulum venereum by Chlamydia trachomatis L1, 2, and 3, granuloma inguinal by gram-negative bacilli, previously known as Donovani bodies, and recently is called Chlamytobacterium granulomatosis or granulomatis, previously known as Donovani bodies. This negative bacilli is now termed Chlamytobacterium granulomatis. Vulval granulomas of a specific chronic infection, such as bilharziasis, bilharzial granuloma, tuberculous granuloma, actinomycosis fungal, foreign body granuloma, and other causes of vaginitis, such as allergic vaginitis and genetic edema. Neoplastic lesions benign as fibroma, lipoma, hidradenoma, papilloma, or malignant as cancer vulva or malignant melanoma. Vascular lesions as vulvar edema, angiolytic edema, vulvar varicosities, and vulval elephantiasis by filariasis. Congenital abnormalities or congenital swelling as hypertrophy of the clitoris, congenital hypertrophy of the labia minor. What are the differential diagnoses of mass in Douglas pouch? Genital causes of mass in Douglas pouch include uterine masses as RVF, retroverted uterus, posterior wall uterine fibroid, posterior cervical fibroid, may be tubal in origin, such as hematosalpinx as a result of ectopic pregnancy, hydrosalpinx or pyosalpinx after conversion of the content of the tube into pus by infection. Ovarian source of a mass in the Douglas pouch, such as prolapsed ovary, that may cause a deep dyspareunia. The ovarian pain is similar to testicular pain in males. Non-neoplastic ovarian swelling, such as leiotomas, follicle cysts, thecal lutein cysts, and these are all non-neoplastic cysts that may be felt in the Douglas pouch. Small size ovarian neoplasm, they may be dropped in the Douglas pouch and felt as mass in Douglas pouch. Extragenital causes of a mass in Douglas pouch include cul-de-sac lesions, such as pelvic hematocele, mostly due to disturbed ectopic pregnancy, chronic disturbed ectopic pregnancy, pelvic abscess, which are sites of, what are the sites of pointing? Sites of pointing in the gluteal region. Why? It is a pelvic in the Douglas pouch. How it can point in the gluteal region? Because pus takes the way to the outside through the pudendal canal to the gluteal region. This is an important question. Pelvic tuberculous peritonitis, pelvic endometriosis may be felt as masses of Douglas pouch nodules, endometriotic nodules in Douglas pouch, and maybe endometriosis of the rectovaginal septum may be felt in the Douglas pouch also. Metastatic implants from the ovarian cancer may be felt as masses in the Douglas pouch. Rectal causes impacted fecal matter or cancer rectum, retroperitoneal masses or tumors, such as retroperitoneal sarcoma, retroperitoneal lymphoma, or simply it may be in the lower pole of a pelvic kidney can be felt in the cul-de-sac as a mass in the cul-de-sac. Tumors of pelvic bone, especially the sacrum, may be felt as a mass in the Douglas pouch, and also retroperitoneal teratomas, which may be rarely seen in the adult females, and mostly it presents in children before puberty. Retroperitoneal teratomas. It is usually related to the coccyx. We come to the instruments. What is this instrument? This is the self-retaining bivalve cascospiculum. This is self-retaining bivalve cascospiculum. And this is another similar speculum with an additional screw or additional joint, and it is called Graves speculum. It gives more dilation of the cervix. This gives some dilation, and this, when this screw is loosened, this upper plate is elevated up, and the plates are separated more. This is Graves, and this is casco speculum. The uses are visualization of the cervix, insertion of any transcervical conditions, procedures such as insertion of uterine sound, insertion of the intrauterine device, taking a cytology of the cervix, taking a biopsy from the cervix or the endometrium, and so on. What are these instruments? These instruments are different types: double-ended Sims speculum. Sims speculum is used in certain position, which is Sims speculum, which is a left lateral position. The examiner is standing behind the patient and insert this plate into the vagina from behind, and traction is exerted over the handle, and so the air is allowed to enter the vagina, and the anterior vaginal wall is clearly visualized. This is a retractor or speculum excellent for visualization of the anterior vaginal wall conditions. We also use it as a vaginal retractor in vaginal operations. What is this? This is a self-retaining, because of this weight, self-retaining overt posterior vaginal wall retractor. Self-retaining overt posterior vaginal wall retractor used in vaginal operations, used for vaginal operations. However, this retractor should be inserted in the vagina under general anesthesia or spinal anesthesia, because it cannot be inserted in the vagina while the patient is awake due to its large and long plate, large size and long plate. This is the uterine sound. This is the uterine sound, and the indication for uterine sound have been mentioned before. This is a uterine elevator, which is inserted, this part is inserted into transcervical into the uterine cavity, and the handle is outside the vagina for manipulation of the uterus during operations, especially laparoscopic operations. These are Hager dilators. This double-ended, this end is smaller than this end by 0.5 millimeter. And this is single-ended Hager's dilator. The size or caliber of the dilator usually is printed here. What are these? These are uterine curettes. These are uterine curettes. This is a sharp curette, single-ended, sharp curette. This is a blunt curette. Sharp curette used in gynecology. A blunt curette is usually used for uterine evacuation in treatment of missed abortion. And this is a double-ended curette, blunt. And this is flushing curette with this end can flush a fluid into the uterine cavity. And this is a spoon curette for surgical evacuation of missed abortion. And this is an OVAC for endometrial biopsy or extraction of missed intrauterine IUD. And Randall, also the same indications for Novak. Novak and Randall curettes have a cavity for irrigation or suction. Irrigation or suction. This end fits to the mouth of a syringe. These are the ring forceps for stabilization of the lips of the cervix during vaginal operation, intrauterine operations, such as uterine evacuation, DNC, dilation decretage, and so on. This is a sponge forceps. This is a sponge forceps for whipping the cervix and the vagina with a gauze, which is held here. You should know that this instrument and this instrument have locks. This is a lock and this is a lock. While these have no lock, this is an ovum forceps, which is used for evacuation of uterine content in cases of missed abortion, incomplete abortion, or inevitable abortion. And the contents are grasped between these oval plates. This is a single-toothed tenaculum or volcellum for stabilization of the cervix in gynecologic, not surgical operation. And this is a double-toothed, and this is a multi-toothed cervical tenaculum or volcellum. This is a Boozman dressing forceps for dressing of the vagina, and we use it for extraction of missed intrauterine IUD when the threads are cut. This is an olive cannula, and this is screw cannula. These cannulas are inserted in the cervical canal, and we use it for hysterosalpingogram performance. This is an iris spatula, and this is a brush. The iris spatula, this end is put in the external cervical os, and this blade is rotated for 360 degrees for obtaining cervical cytology for Pap smear, and this end takes the posterior vaginal cytology, and this brush is inserted and rotated clockwise or anti-clockwise for 360 degrees to obtain the endocervical cytology. These are pessaries. This ring pessary is the most commonly used pessary for management of pelvic organ prolapse in cases not suitable for surgical repair, such as pregnant ladies or patient unfit for surgery. This is another pessary which is used usually for treatment of chronic inversion of the uterus, chronic uterine inversion in patients refusing surgery or unfit for surgery. And this Hodge-Smith pessary, which is used for correction of RVF with prolapse. These are catheters, urinary catheters. This is a straight female cametal catheter with stellate to avoid its closure. And this is shaped female catheter. This is self-retaining double way Foley's catheter, double way Foley's catheter, single way Foley's catheter. This is for drainage irrigation, one way for irrigation and the other for drainage. And this is the Foley's catheter without filling its balloon. These are Nelaton catheters. of different sizes. Each size has a color. These are the obstetric forceps. Gyne forceps is the only forceps that have no pelvic curve. So all the forceps has cephalic curve. This curve is the cephalic curve, and this curve is the pelvic curve. This is the pelvic curve, and this is the cephalic curve. All have cephalic, should have cephalic bed. All the forceps has cephalic curve. Most of the forceps has pelvic curve, except Gyne forceps. Gyne forceps. Gyne forceps has no pelvic curve, so it is used for rotation and extraction of deep transverse arrest in occipital-posterior position. Pepper's forceps is designed for extraction of the aftercoming head of breech, These are the axis extraction piece, which is usually not used in the modern forceps operations, in which the high forceps is obsolete. This is the vacuum apparatus or ventouse. Vacuum apparatus or ventouse. For the operative obstetric procedures or assisted vaginal delivery, I have a detailed lecture on the YouTube and on the slideshow. You can refer to it for more details and the guidelines of the Royal College. This is the Pinard stethoscope, which is old, for auscultation of fetal heart, direct auscultation of fetal heart sound. It is replaced in the modern practice with the Doppler machine, which is called sonocate. Doppler machine, which is called sonocate. Sonocate registers with this screen the fetal heart rate. This is a manual vacuum aspiration apparatus. This is a marvelous apparatus for obtaining endometrial biopsy, for management of molar pregnancy, and for management of missed or incomplete abortion. It is plastic, uses suction and curettage, which is performed by a plastic less traumatic than the metal curettes. In addition, the bar of suction is helpful here. The contents are preserved in this barrel. These are the retractors. This is the Gyne retractor used for retraction of the urinary bladder during cesarean section. This is the vaginal retractors, Gyne retractors used for vaginal operations and vaginal delivery. And this is episiotomy scissor, which is a heavy scissor, one sharp and one blunt blade. And it has an angle. These are the midline episiotomy types. Midline episiotomy, mediolateral episiotomy to the right-handed surgeon.